Hello, and welcome to the multidisciplinary case-based discussion. My name is Milind Javle from MD Anderson. Along with me on this panel, session will be co-chaired by Flavio Rocha, who is the Chief of Surgical Oncology at Oregon Health Science University. We really have an exciting panel. This includes Dr. Talia Baker. She's the Chief of Liver Transplant and Transplant Oncology at Huntsman's Cancer Center right here at home. And then Dr. Riad Salem, really quite an authority on radioembolization and the Chief of Interventional Radiology at Northwestern. Also, I think remotely, I hope we have Dr. Ethan Ludmir, who is Assistant Professor of Radiation Oncology at MD Anderson. And last but not the least, we have a star, our fellow, Dr. Tin Yun Tang. He's a first-year fellow at MD Anderson, and he's going to be leading some of these discussions and presenting some of the cases. We also have Dr. John Bridgewater, who really needs no introduction to this group. Dr. Bridgewater leads the ABC Clinical Trials Group in the UK and is a professor at University College in London. So I welcome you all and look forward to a very productive discussion. We hope this will be interactive. Unlike some of the prior sessions, we hope that this will also lead to engagement from patients. So please make your way to the microphones, interrupt us when you need to, because we really want you all engaged. Thank you. So over to you, Tin.
All right, well, let's get started, everyone. So as Dr. Javle said, we're going to be talking about 3 cases in total over the span of the next hour and a half, and we'll just hop right at it. Feel free to interrupt at any point in time, and I'll try and keep an eye out for people at the microphone to slow down the slides if necessary. So, as we all know, cholangiocarcinoma is a very complicated disease. There's a lot of moving parts involved, from initial diagnosis to management, and it really is a multidisciplinary care team at this point in time. From you have interventional radiology doing a lot of the biopsies, you have radiation oncology doing proton, Y90, you have surgery involved, of course, you have liver transplant involved. There's so many pillars to medical oncology care now, and we're just going to go through some of the nitty-gritty things too over some of the fancier molecular testing that we heard about in some of the earlier sessions too, over the applicability in a clinical setting for a lot of these molecular testings. So we're going to get started with our first case at this point in time. So this is a young woman. She's 48, and she's just doing her normal medical health things. She's getting an annual physical. She goes to her local doctor. At this point in time, she is actually overseas, and she just gets routine laboratory work as part of her annual physical. She's seen to have an alkaline phosphatase of 232, an AST of 76, and an ALT of 58. For members in the audience that are not clinicians, alkaline phosphatase is a marker that leaks from both bone and, for us, the biliary tract. AST and ALT are essentially markers that leak from liver cells themselves. So we're going to go with the imaging workup. This person has abnormal liver enzymes. Sometimes a person gets imaging to follow up for that. This is a little bit of a skip. She did get an ultrasound that was followed by this CT abdomen and pelvis that you see ahead of us. Now, if members of our panel could please weigh in a little bit on what are some of the findings that they see on this CT.
Riad, you're
a resident radiologist.
So it looks like there's a predominantly right-sided mass, probably extending into segment 4, or the left lobe, sorry. Predominantly on the right-hand side, it appears to have a lot of necrosis. It's multilobulated and sort of ill-defined. It may even have some satellites or some other small nodules up in the dome, and it has that peripheral enhancement. There's a little bit of enlargement of the left lobe, which suggests that maybe the right portal vein is also compressed or invaded. And from this distance, I can't see lung nodules or lymph nodes, but those are the things I would be looking for. But from an imaging perspective, this looks like a classic cholangiocarcinoma.
Yeah, I was wondering, thank you. That was, I think I could see the same things, but as always, we're always asking for more cuts and more images. But I wonder what we have, maybe Dr. Baker can comment on the resectability of this lesion.
So, absolutely. So, sorry. Oh, thank you. So I think at this point, again, we'd need more cuts and images before we could decide that, mostly because of the issue of potential portal vein invasion and how much of the liver we would have to take out. I certainly wouldn't say this was unresectable, but I certainly would consider this for multidisciplinary downstaging to a point where we could offer either resection, or I always keep in the back of my mind, if it's not resectable from a technical standpoint, whether we can get someone to transplant.
Yeah, and I think that's a good point. And there's also what we surgeons look at is there's anatomically resectable and biologically resectable. And so when you may have something that's technically feasible, but the biology may be adverse. So when you start looking at multifocal disease, bilobar disease, again, it's not that we can't scoop tumors out of the liver, but those, unfortunately, that disease biology is unfavorable. And so even after surgery, recurrence is probably universal.
All right, well, thank you to all of our panel members. Of course, we have a limited amount of cuts because of the format of this presentation. I do apologize for that. But we're kind of getting a little bit of our head of ourselves straight to treatment planning. But at this point in time, you have abnormal labs. You have a woman that essentially feels well, no real problems, not even any yellowing. So for those in the audience, jaundice is something that you see a lot when some of the bile ducts themselves get compressed and blocked. So at this point in time, you have imaging findings, you have abnormal labs, and you want to figure out if it's cancer, because it certainly on the differential are other things. There, perhaps as our radiologist mentioned, that this is probably a pretty classical image for some sort of cholangiocarcinoma. But that being said, tissue diagnosis is important. So this lady, she gets a CT-guided biopsy, and she has 6 cores taken. So you have a pretty big needle, and you kind of take these core biopsies, and you send it to the lab, and you try and see what it shows. And actually, on the second line below, you can see that for these 6 core biopsies, which is actually for a patient, 6 passes into the liver and out, they don't see any cancer. You see some bridging fibrosis, so you see some fibrous changes in the liver that suggest some sort of chronic liver disease, perhaps, but they don't actually see any malignant tissue. So at this point, the really question comes down to, well, I need to know more about this patient at this point. So we'll just kind of go through some of her other medical things. From a past medical history standpoint, she really only has some mild dyslipidemia. Her LDL is high, but the rest of her cholesterol and whatnot is essentially okay. She was overweight at one point in time, but she started working out. She went through a lot of exercise training programs, and she's essentially a normal weight at this point in time. She had a cholecystectomy when she was very young. Her social history is not particularly remarkable. She's a healthy young woman. Family history is also not particularly remarkable. No breast cancer, no colon cancer. There's some diabetes and some depression. So, things to kind of note when we start thinking about, well, what are some risk factors for developing cholangiocarcinoma potentially? And some of it is just chronic liver disease. For instance, in the U.S. now we see a lot more incidences of perhaps NASH. Now that's of course much more associated with hepatocellular carcinoma, which is a different cancer altogether. But some of these chronic changes in the liver, on her pathology, she did have this fibrosis. So pretty standard, you work up a lot of these patients for other chronic liver diseases. Hepatitis, hepatitis B is a big player in cholangiocarcinoma risk around the world. Perhaps not as much in the United States, but certainly in the rest of the world, hepatitis B is a really important one. And a lot of her other kind of enzymes are essentially normal at the bottom. Anti-smooth muscle antibody, anti-mitochondrial, and liver kidney. Those are kind of antibodies for autoimmune disorders. Primary sclerosing cholangitis, autoimmune hepatitis. These are both autoimmune disorders that could be associated with both chronic liver disease and ultimately essentially a risk factor for cholangiocarcinoma. So essentially what we have is a young woman. She has elevated lab tests, and we had 1 round of biopsies, and it doesn't really show much of anything. So at this point in time, for the medical oncologist, tissue is very frequently the issue. So you go through a second attempt at a biopsy. At this point in time, she moves to another institution, and they decide, well, let's try and get some more biopsies and see what it shows. And this time, at the very least, she gets another round of CT-guided biopsy, and this time it does show moderately to poorly differentiated adenocarcinoma, including liver. So for the more astute, I did not include all the staining here, but the staining was consistent with a cancer that started from the hepatobiliary tract as opposed to a primary liver cancer or a metastatic foci from a different primary cancer. So at this point in time, she's staged with a kind of CT chest, abdomen, pelvis. We had some slices taken from that staging examination that we talked about earlier, and she's staged as stage 3B. Clinical T2, a couple of suspicious nodes, and no obvious distal metastatic disease. Her liver enzymes start to worsen a little bit more at this point in time. As far as her LFTs go, total protein is okay. Her total bilirubin, this is the number that a lot of people associate with turning yellow. A lot of the times once this number hits 3, 4, 5, that's when you start turning yellow. Your eyes may turn yellow, your skin may turn yellow, you might start to itch. Her AST and LTs are also a little bit increased, perhaps suggesting a little bit more inflammation in the liver tissue itself surrounding it. And this alkaline phosphatase that at this point in time, we are using as a marker of specifically bile duct cells turning over is going up still, up to 596. So at this point, I would question the panel if perhaps they think there are any other tests that could be helpful to help determine what her treatment options are at this point.
So I thank you, Tin. I think he Tin made the case very well. This patient went through months of workup with all these tests that Tin displayed earlier, autoimmune tests, etc., whereas she really just needed a biopsy at an experienced site where people perhaps just needed to repeat a biopsy. So we illustrated this because it's quite typical in terms of workup. A lot of time is lost in workup and getting to the diagnosis. So do we have John Bridgewater online? John, are you there? Oh, yes.
Yes.
John, so this is a patient, as you saw, and I just also point out that this patient had seen our surgical oncology, and for reasons Talia mentioned, vascular involvement, which was not seen on the prior cuts. She was unresectable. So she had T2N1 tumor, multifocal disease. What would be your favored option based on the current data?
Sorry, I'm slightly disadvantaged and we haven't been able to see the slides just yet.
You mean the radiology?
Correct, yeah. We can see you and it's wonderful, but...
Sorry, John, you'll have to just take our word for it. This is multifocal cholangio with positive nodes. And I hope we can fix that slide situation with you.
Well, that's great. So we do desperately need some a tissue diagnosis and to get a bit more information about this cancer. So in this situation, I would steal the scans and show them to my favorite radiologist.
Great. So
who would do something that others cannot do. Yeah.
Well, we have our favorite surgeon here, Flavio.
Well, so I think there are a couple things here that obviously of concern. So certainly poorly differentiated tumors are concerning. The fact that the nodes are positive are concerning. However, that used to be considered stage 4A disease. It has been actually now downstage to 3B in the new AJCC edition. And so what that's allowed us to do is say, okay, perhaps patients with positive lymph nodes are eligible for surgery if they meet the technical criteria. What I would say is, I'm sure that I know the surgeons at MD Anderson quite well, so I'm sure if they determined that it was not resectable, it's likely the case. That being said, I always encourage patients to get second opinions. I've had people come to me for second opinions. I send patients elsewhere for second opinions. I always tell them that if you get a second opinion on your car or a house, there's no reason you shouldn't do it with your life. So. But if there was a chance of resectability, even in this case with these adverse pathologic features, I would still probably recommend some upfront systemic therapy. And again, the idea is to get control of the disease before you embark on a major operation.
All right, well, yes, the question from the audience.
Yeah, can we talk a little bit more about vascular involvement, what that means, why it's not technically resectable at that point, and if in the future, if you have vascular involvement and you were to shrink it, or you then could potentially go resectable?
We'll let Dr. Baker, who's our transplant surgeon, comment on that.
Sure. So vascular involvement doesn't really technically keep you from resecting someone, but as already been mentioned, the importance is once you have vascular involvement, the likelihood of being able to resect and then leave you free of disease, including circulating tumor cells, which are positive for disease, which will sit down and cause more metastatic disease, is very low. So I think one of the most exciting things that we've learned over the course of the last probably decade as we've kind of embarked on these intrahepatic cholangiocarcinomas is that disease is the most important thing that we have to control prior to offering surgical resection. So again, there's a lot that we can do technically. It doesn't take away from our ability to cut through the vessel, put it all back together, and take out that piece of liver, but we know that we won't be helping in any way if we do that. So using upfront systemic chemotherapy to control disease is certainly a great option, but especially in the case of vascular invasion, we've learned from our IRIO colleagues that we can actually dissolve the tumor within the major vascular structures that are being invaded, especially when they're within the liver. For example, in this picture, again, we couldn't see the whole picture, but it looked like there might be some right portal intrahepatic involvement with the tumor. So using things like the methodology that Dr. Salem has really been the one to bring to the fore in this disease, TARE or transarterial radioembolization, as part of the downstaging treatment to surgery allows you to get to a point where you can technically resect the liver and also offer a better option for long-term overall survival.
I think we can go on then to the next.
All right.
Did she get chemo?
Well, while all of this was happening, and as we're kind of getting at, treatment planning is not trivial. There's a lot of different physicians that you need to speak to and plan out carefully with. And while this is all going on, we have our favorite molecular testing that actually came back. Nowadays, the turnaround can be 3-4 weeks or so, give or take, if you're at a rapid center. But so we have essentially 2 different molecular tests that we're looking at right now. So this fusion transcript panel, this is from a tissue biopsy itself. So as we kind of talked about, the second biopsy did show, in fact, cholangiocarcinoma. So they took that tissue sample, they took it to the lab, they extracted both DNA and RNA, and they sent it out for molecular testing. Actually, this would be an in-house panel at a different university. And this showed on specifically a fusion transcript panel, and this is for the benefit of the audience members, that there is a little bit of difference between mutations and fusions. Mutations, that kind of testing is usually done from a DNA level source. But that being said, fusions, which is kind of new gene products almost, which results from a fusion of 2 different genes, that's usually done from RNA itself. And we'll talk about at a later case how sometimes this can be a little bit challenging, some of the differences between DNA and RNA and successful molecular testing. But for now, we see that from the tumor itself, we see a fusion. We see a FGFR2-BIC1 fusion. This is a well-characterized fusion in the cholangiocarcinoma field that is thought to activate FGFR2. And we have down below a liquid biopsy panel. We were talking a little earlier about cell-free DNA. This is, of course, called very many different things: circulating tumor DNA, cell-free DNA, liquid biopsy. So this is our in-house panel at MD Anderson. It really is rather sensitive. We're able to detect mutations, at least in our tech specs, down to 0.3% of a VAF. But so you can see right here that all that we really found actually on this liquid biopsy, which actually does also include fusion testing, we only found this CDKN2A mutation, a point mutation at a very, very low variance allele frequency. And so that would suggest that this mutation is very rare and perhaps potentially a subclonal mutation. So I would ask some of the panel members what their interpretation of these molecular testing are and whether or not this influences their thoughts on what kind of treatment this patient is a candidate for.
So I have to preface this by saying this patient, she's probably online listening to the conversation. She's going to smile, but she saw me and she saw my socks. I like colorful socks. And I said, I'm going to think outside the box, and I don't want to get any chemo. You have this FGFR fusion, and why should I get any chemo? So John, are you are you still there? This is a lady who has FGFR fusion. She has multifocal cholangio. She says that she has FGFR fusion. She says, I'm not going to get any chemo.
So that's that's a very wise and far-sighted statement, because we know that that there are targeted therapy options for this patient. Primarily in the context of the 3 randomized studies that we have currently running, that compare targeted therapies, so small molecule treatments for these fusions, comparing them to what is currently still the standard of care in most parts of the world, the standard cisplatin gemcitabine chemotherapy. Arguably and consequently, these studies are out there, and arguably you could say that we haven't really got the hard data to say that targeted therapies are as good as chemotherapy in right up front, and certainly in my institution, they wouldn't let me do that. They wouldn't let me give targeted therapies up front because I haven't sort of persuaded them sufficiently well with the data to which they are generally accustomed. So, but nevertheless, there are, there are some reasons why you may be able to get away with it, and I'm sure, Milind, you have cunning methods of getting hold of these small molecules to offer patients outside of studies. I've actually only ever been able to do it once on medical grounds. The patient would not have been able to tolerate systemic chemotherapy, and I persuaded my local drugs and therapeutics community to permit me to use a small molecule to treat this cancer. I mean, the chances of success for this particular cancer, and I thank you, somebody sent me the slides, I can see them now. For a big one and pretty much nothing else apart from the CDKN2A, the chances of success are actually extremely good, and yeah, at least if you look at certainly the data that we have, at least as good as the chemotherapy.
Thank you, John. So I have to say that this patient was presented at our multidisciplinary clinic a meeting, and we have our counterpart of Riad Salem, who's not quite Riad Salem, but very good, Armin Mawash, and he weighed in. So can you go to the next slide? Is liver therapy directed therapy indicated? So Riad, we have probably an effective targeted therapy here. Do you still think that you would still consider liver directed therapy?
Well, thinking outside the box, I think you mentioned before, is really something we want to do with this patient, young and healthy, and we want to, in some cases, try to see if we can get them to cure. That's what personalization of treatment and decision-making actually is, and obviously the only chance for this person in the long term is a cure, is downstaging to resection in some form. And Flavio's right, sometimes there's some lymph nodes that technically mean the patient has extrahepatic disease, but sometimes those are reactionary. Sometimes they'll respond after you treat the primary liver as well. And so for something like this, and having worked with Talia for 15 years before we lost her to Utah, this is clearly something where we would advocate the use of some form of local regional therapy and an inherent biologic test of time, because you don't want to operate on those patients that will recur very quickly, as Talia elegantly described. And so we try something local regional, see how the patient does, see what the lymph nodes do, maybe augment with chemotherapy. This is individualized care. This is out of the box, and see how the patient does. Look at how the FLR, the left side of the liver, is looking like to see if they could tolerate a resection, and make a decision in a few months.
Go on, Tim.
All right, so, as we're kind of getting at, we start planning actually for Y90 or liver-directed therapy. But while this is all happening, time's ticking, and actually during all of this treatment plan, her total bilirubin actually starts to increase rather sharply. I think the axis numbers are probably going to be too small to see, but kind of that one peak right there is right before we managed to get her started on targeted therapy, and while all of the Y90 planning was going up. So now the total bilirubin is up, she's turning yellow, she's itchy, she's symptomatic, and this is the diagnostic procedure for it. This is something called ERCP. This is actually probably some pictures taken during the procedure itself, showing where the bile ducts are and where they should be. So you can see that on this image right here, one of the bile ducts is rather narrow. You have two main bile ducts, as we kind of all know. One of them is pretty narrowed right there, something's pushing on it. And the other one, actually, you can't really see any contrast go through at all. You can't even see the duct itself. So there's some pretty marked compression right there. And kind of as we're getting at, multidisciplinary care is very important at this point in time. Perhaps someone from our panel would like to weigh in on some of these nitty-gritty things over plumbing, which really is a really non-trivial problem for very many of our patients, and actually for treatment too.
I think we can go on, and Riad could comment at the end of it.
So, what happens is that while we're planning for Y90, this patient actually gets started on erdafitinib. So erdafitinib is not a medication we necessarily jump for purely in cholangiocarcinoma, but this was in 2019 actually, and at this point in time, erdafitinib was what was available, and it had approval actually in urothelial cancer. So she starts on this medication at the initial dose of 8 milligrams, and at this dose, she has some pretty significant complications. She gets something called central serous retinopathy and hyperphosphatemia. Now, both of these are actually probably what we would consider quote unquote on-target side effects because of the fact that it has to do with the activity of the drug itself. There are FGFR receptors in both the eye, and it also plays a really big role in bone turnover. So the hyperphosphatemia and some of the issues with the retina that you see in these patients, they are actually almost directly related to the therapy that we're giving itself. So she starts on this therapy, she gets Y90, and she gets, she has ongoing issues with vision. At this point in time, I don't believe we have any ophthalmologists on our panel, but we send her to ophthalmology. They keep on working at her, trying to troubleshoot her vision. And we actually ultimately had to dose reduce her over the course of these 7 months, twice to 6 milligrams and 4 milligrams. There's a couple of dose reductions that's allowed on the FDA label before you have to probably discontinue on the basis of side effects. And we start her on Savellumir, which is a phosphorus binder to decrease her hyperphosphatemia. And so she has stable to partial disease without chemotherapy for almost 7 months. And then at the next stage, and about 7 months later, she gets another restaging examination. And at this point in time, she unfortunately shows progression in the liver and the lymph nodes. The erdafitinib is stopped at this point in time.
So I think what I want to point out in the prior slide, can you go back again, please? It was almost, the Y90 was given Riad in November 2019. It took us a while to get erdafitinib. So, for several months, she was on no treatment except for Y90. And really the progression, so the disease was controlled for nearly 1.5 years. And only a last part of it, the 6 months of that 1.5 years was on the FGFR inhibitor. So I attribute a lot of her disease control really to the Y90. And to the tail end of it, we did add the FGFR inhibitor. So John, she had a nice response. However, it was not a tremendous response. The patient had the erdafitinib for 7 months. And to your point, the trial would be appropriate, but at that time there was no trial. So she got this off-label erdafitinib. And now there's progression after erdafitinib, and she again refuses chemotherapy. What would be your next option?
So just as an aside, this is her CA19-9 that is a cancer-specific tumor marker when sometimes we use and can use in cholangiocarcinoma. What we're going to focus is on the left side right there. The peak of that is actually right before some of the Y90, and you can see that it's going down. And then at this kind of recurrence, we can see it start to increase very subtly on the right side of the curve. So this 19.9, it goes up, it goes down, and sometimes when the tumor progresses, it may only increase a little bit. So we have repeat molecular testing at this point in time. We do another liquid biopsy panel. She has actually a couple throughout this time course to try and see if there's anything changing in her tumor itself that we can measure from a liquid biopsy panel. So getting at some of the difficulties of using these molecular testing, you can see that in some of her later panels done at the same institution, same panel, we actually don't see any mutations, fusions, copy number variations. And this is, compared to really the solid tumor biopsy that we have this FGFR fusion that we found, we're still using that as one of our key treatment criterias, even though we don't really see it on the liquid biopsy. So a lot of the times when we see something on the solid tumor assay, we tend to lean on that as a potential indication for treatment, even if it's not recapitulated in the liquid biopsy testing. So, she decides that she really wants to keep going, targeting this FGFR fusion that we found on the original solid tumor. So she's consented to take part in a clinical trial at MD Anderson. This is one of the drug names was essentially originally TAS-120, or otherwise known as futibatinib at this point in time. Her treatment is delayed again a little bit due to having to figure out what to do over her vision. She developed some cataracts too, although this is not necessarily a classical side effect of the FGFR inhibitors. Generalized kind of issues with the cornea and the retina are things that we see a lot in our patients. So in August, she starts treatment with futibatinib on our clinical trial, and she has this for almost 6 months. So another kind of half of a year without chemotherapy that we've bought for her at this point in time. And she unfortunately does progress very recently.
So that's where we are now. Lippy, I'm going to pick on you a little bit. This lady had erdafitinib. I'll summarize. She had Y90, very nice response, erdafitinib for 6-7 months. Then she had progressed, and now she got futibatinib for about 4 months. She progressed on that. She's still doing well. She has metastatic disease now in the liver, some metastatic disease in the lung, and she wants to know what are her future options. Rule out chemo, and I think she chose well. It's almost 2.5 years without any chemo.
That's terrific. I would say step one would be to do a ctDNA analysis to see if she has any mechanisms of resistance. Do we know anything about that at all?
CDKN2A was all we had on liquid biopsy.
Sorry.
We don't really have any tumor biopsy.
This was after the futibatinib?
After futibatinib, and it was also there before. It was there at her original panel as well, at diagnosis 2 years ago. So I don't think it's acquired. Yeah.
So I guess the question is she progressing through futibatinib through an on-target mechanism or an off-target mechanism? And liquid biopsy tends to be relatively sensitive for identifying mechanisms of resistance, but it's also possible that she did progress through an on-target mechanism and we just didn't pick it up on liquid biopsy. So if we wanted to go down another FGFR inhibitor route, there's certainly a couple of clinical trials that are going on right now of next-generation FGFR inhibitors. But if we think she had a short period of time on futibatinib, only 4 months, and she is not progressing through an on-target mechanism, then I would think about other systemic therapy options in other clinical trials.
John, you raised your hand.
Yeah, I thought Lipika was going to tell us about this, but essentially not all liquid biopsies are made equal. There are some that are more sensitive, that look for the famous mutations that Lipika published really years ago now. Looking at these and give us a really good clue as to whether some of the newer FGFR inhibitors stand a chance of working. On retrospect now, I mean, we know now that futibatinib would not have worked in some of the patients we've had in the past anyway, because we understand more about the detail of the emergent clonal mutational resistance that causes the trouble here. And so there is a there is a case for just going through which liquid biopsy has been done and what are the platforms that have been used, and and even considering doing another tissue biopsy at this stage, just to really squeeze the most out of this, squeeze the most out of the targeted therapy before you move on to something else.
Thank you, John. We will certainly do that. I'm going to show a couple of slides and then really turn it over to Riad. Can you go a little bit
Yep.
further?
Give me. It's,
Next slide. Next, yeah.
It's lagging a little bit. Give me a
Go
sec.
further, like you were before. Yeah, next. So I think this is some work that my fellow had done before, where she looked at FGFR and prognosis of concurrent mutation. And you can see the second row over there is CDKN2A and CDKN2B. These people actually have a poorer prognosis. So while we are very happy with FGFR fusion, and it gets me really excited, I have to temper my enthusiasm when you see that mutation alongside. Next slide. So this was seen with infigratinib. We haven't published that data. This was seen with futibatinib, as John mentioned, progression-free survival with FGFR fusion, targeted therapy, is also dependent on concurrent mutation, and PFS is lower with CDKN2A mutation. Next slide. This was also shown with pemigatinib. Sorry, there's a crowded figure, but just to show you the blue survival line on the right, which is lower, is those with tumor suppressor gene mutations with pemigatinib. So despite the presence of FGFR fusion, these patients actually do relatively poorly with concurrent CDKN2A mutation. Next slide. Futibatinib, very elegant data shown by Lippi earlier, which showed that futibatinib is active in a lot of acquired mutations. But I think we shouldn't forget that 20% of patients who have FGFR fusions don't really have a good outcome with FGFR inhibitors. And this may be because of concurrent mutations such as CDKN2A, P53, and KRAS. Next slide. So this was activity of futibatinib shown by my colleague Funda Merrick along with Lippi, which showed futibatinib works. That's why she got that second line. But these are two new agents. One is the relay agent, which Lippi displayed in the triple meeting, and the dark green lines are patients who had prior FGFR inhibitors. And next slide. This is some work we are doing with TT00420, which is another small molecule inhibitors which seems to target resistant mutations. Next slide. And these are patients, the response on the left reflect patients who do not have FGFR aberrations. On the right, the greens and the blues reflect patients who had FGFR aberrations and got TT00420. And next slide, which is my last slide. So this is a crowded slide which shows that with this agent, these are on the left are the various agents that were given before that included pemigatinib, derazantinib, erdafitinib, and so on. And most of these patients had stable disease or partial response following treatment of this drug. So fortunately, we hope, like Relay 4008, there are other agents in this space that may offer patients options beyond the first-line FGFR inhibitor. But clearly, this is a different story to some extent because this patient had CDKN2A before, and then we will follow John's recommendation of rebiopsy. Now, I'm going to turn it over to Riad for a few minutes on his experience with treating intrahepatic cholangiocarcinoma with Y90. So, Riad, we realize there's no randomized trial, So how do we offer this to patients, and what is your plan in future? Will we have randomized studies to show benefit of Y90 so that this will be applicable to patients and beneficial, such as it was in this state? And then after Riad, we'll turn over to the next case.
Thank you for that question. I've actually never had that question before. I'm kidding. So, of course, one of the challenges of getting some of the randomized trials with local regional therapy early in some of these conditions is no different than the challenges of getting surgical randomized data in this setting, right? We accept that surgery improves overall survival if you can operate on colorectal cancer. There's really no randomized data, but that's what we do, and we do everything we can to converge on that final event, which is resection. It's really quite challenging, having done a couple of randomized trials, adding a local therapy to a systemic therapy. When do you start? When do you stop? Is the toxicity due to the local therapy? Is it the chemotherapy alone? Is it a combination? It's very, very challenging to do that, and I think Juan was talking earlier about sort of surrogates, non-OS surrogates that we could use for reasonable endpoints. And I do think that this is the kind of stuff that we would need for local therapies, either resection or tear, et cetera. So I don't know. I don't think there's going to be ever large first-line randomized trials. I mean, that case that you showed, because the patient didn't want chemotherapy, Armin then said, hey, let's try something else. But I suspect that if Armin hadn't said that, that person would be on systemic chemotherapy. So the cycle is always there unless you break out of that cycle. And in general, young, healthy patients, you want to try something outside the box because you want to get them to resection. And there are many patients like this, even this much disease, that we've downstaged, anecdotally, of course, not with level 1 evidence, that Dr. Baker has resected. And so I think because of the skill set that we now have with something like TARE, that I think is much more effective than, say, a chemoembolization, because of it's just extremely high-dose radiotherapy, very focally in that area. We can do new things like hypertrophy the left side and get very high response rates. And the surgeon that's done the most on the planet resecting those patients is sitting to my right. So it'd be nice to get that data. I don't know that we're going to obtain it, but the kind of thinking that you displayed at your tumor board saying, hey, maybe we can do a very strong cytotoxic treatment before our standards would be, I think, a welcome addition.
So I just want to add a note of caution. These days, we're seeing a lot of people get Y90 in the community, and it's not for everybody. And it can lead to liver failure, it can lead to cirrhosis, it can lead to complications. It has to be done by people who are adapted and have a lot of experience doing it. This is an out-of-box indication, and I'm going to speak for John. John, I presume this is not going to be possible in the UK for a reason, because it's very specialized therapy at very specialized centers by experts, such as we have here in the panel.
Yeah, I was gonna, we have a question? Yep.
Yeah, hi, thank you. I was just wondering what your opinion was on the role of external beam radiation, perhaps SBRT, to downstage patients instead of Y90.
Great question. And we have Dr. Ludmir.
We have Ethan here. Dr. Ludmir is assistant professor of radiation oncology at MD Anderson, and really a bright young guy. He has all the answers.
That's very kind and wildly untrue. No, but I appreciate the question very much. And I echo a lot of the points that Dr. Salem said about the challenges of obtaining that sort of evidence with local therapies and the nuances, and as Dr. Javle pointed out, of having these therapies delivered at centers and by practitioners who do this with regularity and understand some of the nuances and challenges in this setting. So the question regarding external beam, I actually think that external beam would have been reasonable in the setting as well as Y90. For multifocal disease, we often have a multidisciplinary discussion to see whether we think external beam or Y90 would be reasonable. One of the advantages of external beam in this setting is that you could potentially cover some of that extrahepatic disease if that adenopathy is believed to be real or metastatic. But one of the challenges of SBRT is, and I've got a few slides later, is we have a lot of nomenclature. But SBRT conceptually is really a technology that works very well for very, very small tumors. For lesions like this, which are multifocal and large and encompassing a good chunk of the right liver, as you've seen, typically we tend to favor a slightly more protracted course of radiation, typically using either photon-based methods like IMRT. Proton-based methods are reasonable as well. There's no one specific formula or one secret sauce, and we end up converging more typically for these larger tumors to radiotherapy courses lasting about 3 weeks long, where we treat patients Monday through Friday for about 3 weeks.
Great. We had a question here from the floor.
The cancer's so rare and we're kind of spread out all over the place. When should we start shopping kind of for the next thing that we need to do? Because like I'm in Wyoming, and so I'm quite a distance from any center that has expertise in cholangiocarcinoma.
Maybe, John, you could answer that question and also, address the point you're making here. When should patients start thinking outside the box?
So that's an excellent question, and it comes down to the balance between centers of expertise. We stop short of calling them centers of excellence because sometimes they're not, but centers of expertise versus therapy available closer to home. And for rare cancer, there really is no question about it. You should always go somewhere where people do a lot of it. and this, to be able to do this, you need a centralized healthcare system, which curiously is one of the benefits of some of the healthcare systems in Europe. The centralization, seeing an expert, is much easier, in some cases actually mandated. And so when should you, to cut a long story short, when should you see an expert? As soon as you can.
Thank you, John.
Yeah.
I'm going to close.
May I just say one thing
Yes,
to add
please.
to that, please? Thank you. So I think that many of our centers who are really interested in cholangiocarcinoma throughout the country really have developed these multi-D pathways. But one of the benefits that we've learned over the time of COVID is the strong potential for telehealth. And I think as a patient, you should start asking early and get a visit with MD Anderson or any of the other programs around the country that offer these multidisciplinary pathways, or we do it now in Salt Lake. So I think it's really important. COVID has been tremendously difficult for everybody, and especially for those in the healthcare field and who are needing healthcare help. But the real benefit is telehealth, and I think that you should take advantage of that as early as you possibly can.
I think Salt Lake, you have a telehealth program, right, Talia?
Yep.
Yeah. Not too far for you. Yeah.
Yeah, and I think it's pretty important, especially here out west. You know, we're in Oregon, it's a rural state, and so the distances can be large and the disparities large as well. So that's a very good point.
I think, like Dr. Baker mentioned, at the beginning, and then every time you want to plan a change of therapy. Yeah. And you have centers like this, like Oregon or Huntsman, which offer these telehealth services. Yeah.
I was gonna, John, do you have another comment? No, your hand was up.
Just to go back to echo what Milind was saying earlier about caution about Y90. We can't do it in the UK unless you have a lot of money. Not even the insurance companies will fund it. The study, the first line study, the surface study, looking at Y90 versus chemotherapy in Y90 versus chemotherapy on its own, failed. It failed at a relatively early stage. The data is still not published, and it's very. I think it's a shame, because it's very important for us to understand exactly why it did so. And because undoubtedly, as we've seen here with this patient, it can be incredibly successful, but we need to know which the right patient is.
Dr. Goyal?
Yeah. We have two more cases.
Oh, we do, okay. And I just wanted to close real quick then, just because I would be remiss, and Riad would be upset if I didn't mention hepatic artery pump infusion, which is also another local regional therapy option. And what we need to actually do for all of these local regional therapies is do what our medical oncologists have done and get the profiling information, because we do not know what the relationship of a single mutation or multiple mutations on local therapy is. So, all right, as Dr. Javle suggested, he's going to keep me on task. So we'll switch gears here, and this is the second case. And so this is now a 59-year-old gentleman that presented with a pretty classic presentation, I would think, for any kind of biliary problem. So right upper quadrant pain, radiating the back, and some amber-colored urine. Some comorbidities. The only thing of note there is that the patient was on methotrexate, so it was relatively immunosuppressed. You can see the liver function tests are not horribly elevated. The bilirubin is 1.9, and the CA19-9 is actually on the lower side. So hopefully we can, next button here. Okay. Here's the CT scan. Perfect. And I think hopefully we're able to get all the images there for our colleagues to get a sense. And this is a very typical appearance. And you'll see the dilated bile ducts converging down to the hilum with a mass. And that would certainly explain the liver function tests. Okay? We've got a good image of that. Here's then the corresponding MRCP. So this is an MRI that specifically looks at the bile ducts, and you get a three-dimensional reconstruction to see where the tumor may be. Again, you're looking for secondary signs, so you're looking at dilated bile ducts, and as they're coming to the middle of the liver, you see the signal drop out, and that gives you a sense of the biliary anatomy. We can spin it so you have a better sense. Okay? So I think from a workup perspective, if this patient was sent to you, Dr. Baker, how would you proceed?
Thank you. I think that an ERCP would definitely be a great way to go, so that you could really define where the tumor is, and most importantly, from a potential surgical intent, where the tumor was limited to, whether it was up in the right and left side of the liver, or whether it was simply limited to the outside of the liver, the hilar region. So I presume that's where you went.
We did. And so you can see then the ERCP images, and this is done, again, via endoscopy by gastroenterology, and you can see the dye being injected into the bile ducts, and you get, again, a picture that's similar to the MRI, but perhaps with a little more detail to see where the lesion may be. That kind of gives you the end there. And patient had a dilation, and a stent was placed to relieve the symptoms. Now, here's the rub. These are the biopsies, and they were read as inflammation, stricture, but no definitive evidence of cancer. And I'm wondering if I see my colleague, Dr. Hay from the Netherlands, who is a pathologist, perhaps she can look at these slides and overturn that decision. But in the meantime, I mean, this is a scenario that's not uncommon. Yeah. And so, Dr. Hay, do you have any comments?
Yes, so there are some red arrows. Maybe with my microscope, I would zoom in there to see if those cells look atypical. But inflammation can also cause a lot of atypia. So it's a difficult diagnosis, especially with just a few cells. Immunostaining could help.
Thank you. Yeah, and this is a challenge, right? Because we are putting this expectation on our pathologists. And perhaps I can ask Dr. Javle or Dr. Bridgewater, is this enough for you to give chemotherapy or even TIN?
Are you going to prescribe GemSys?
Well, I think always a little bit more information is always helpful, whether it's molecular testing or additional stains, particularly some of the IHC stains and pathology can be helpful sometimes, but diagnosis, as we are kind of getting at, is not trivial for a lot of our patients.
So Flav, for us, we have the luxury of cases like this. We would present in our liver multidisciplinary meeting and see what the group feels. Look at biomarkers, look at CA19-9, that sort of thing.
Yeah. Okay. Let me move on. So, of course, so we have to have a surgical case in there. So I think this is a scenario, and perhaps I can pick on Dr. Baker again. Patient actually ended up having multiple other procedures, still with no diagnosis. And so this is the challenge we're often faced with. So we sometimes have to go to the operating room with a plan to make the diagnosis on pathology, on the full specimen. And so, but I'm just curious from what you saw, Dr. Baker, is this somebody you would consider perhaps for transplant as opposed to resection?
Well, again, it depends on the whole patient. So you have to see the patient, see what their underlying liver disease, whether there was any evidence. I didn't see on the ERCP, although it was just a single image, that there was evidence, for example, of any sclerosing cholangitis on the liver, which would make a difference. And you did mention a drinking history, et cetera. So you'd want to know what the baseline liver disease was. But I would try to get to an operative plan at this point. I'm going to be a little bit cagey because I'm not sure what that would be. But one of the real benefits that we have today in the surgical field is that resection can include a radical resection, which is a transplant, taking out the whole liver and putting it back in. So I have to tell you, I would hope that we could get to a resection, probably a left side hepatectomy and caudate, but having seen the films in a limited fashion, I'm not exactly sure what that is, but I wouldn't rule the patient out yet. But I really favor some type of adjuvant therapy up front to see what the biology of disease is before you approach these patients surgically. You don't have a diagnosis yet, so it's a little bit more difficult. And the only other thing, because I had a patient like this just a couple of months ago, I would check IgG4 just to make sure this wasn't an inflammatory-based lesion as well.
Yep, no, these are all great points. Milind, do you have something to add?
Yeah, I was going to pick out my friend, Dr. Gores. Dr. Gores, you have published on this sort of situation before, where you have a stricture without a diagnosis. Do you think, what would you do at Mayo? Any additional testing?
Thank you, Milind. We would look, I think when we look, is there a mass on the MRI? So,
Yeah, there's a mass that's under 3 centimeters.
So there's a mass on the MRI. So this patient has a malignancy. We would look like you did at the CA19-9. I would say that in our rich experience, the biopsies that you showed are the least helpful, the brushing second, and then we would do fluorescent in situ hybridization. There also is a test on bile that the group at Pittsburgh has published in Gut last year, which also has reasonable sensitivity and specificity. I think one of the issues nationally is that these advanced cytologic tests need to be expanded more across the country. You know, we have an implementation defect there. So I didn't see anything that said the patient was not resectable. We would not go on the transplant unless it was definitely not resectable. I will say that issue will probably not die. I've seen a preprint of a paper from Pierre Clavier in Europe with 23 centers. They had 120 patients, and patients generally do better with transplant.
Yeah, I would say this is one of the, Dr. Salem?
I just want to add one thing. I mean, this is obviously a very challenging area for diagnosis. Like you said, you get a bunch of tissue and you're not going to make anything of it. So one of the things that we've been working on over the last 5 years and actually already published a few papers on is direct biliary access endoscopy. So us IR and GI, we get into the bile duct for them, and now you actually see, rather than just secondary signs of contrast, we actually see the lesions and we're biopsying the tissue and getting real tissue. So your colleague doesn't need the arrows. It's clearly malignant. So that's one of the things that I think we're developing, and I think it's going to be the next level for this particular condition, because it's sort of no man's land up there. You can't really do much. The biopsies are never helpful, but with endoscopy, you can get exact tissue.
Yeah, I think the challenge, as we talked about burning bridges, is also not getting a biopsy that's going to preclude you from potentially a transplant as well. So that's the other.
The biopsy that Dr. Salem is describing wouldn't preclude from a transplant because it's not going through the peritoneum in any way.
Right. But often we are sometimes seeing folks, perhaps at other centers, that are getting EUS-guided transperitoneal or transbiliary biopsies, which would.
And Flavio, I don't know, John, if you have the same experience. Unfortunately, we see a lot of patients who have had multiple biopsies, ERCPs, infections, and cholangitis, and all kinds of complications in an effort to get a diagnosis. And people are, getting abscesses and so on, whereas they could have actually started treatment even without necessarily a strong pathological diagnosis like we're used to getting.
Correct, and this is something we often see in the surgical world, is we're offering very major hepatectomies or liver transplant without a clear diagnosis. And this is something that, again, I can stress more about having the experience and going to a center that does a lot of these. So we'll talk about the resection capabilities, but I did want to address Dr. Gore's point, is that there are now multiple studies perhaps showing that transplant, when you're talking, retrospectively comparing, may be somewhat better. However, these are obviously very tainted with selection. But the U.S. Extrahepatic Biliary Consortium did publish a series in the Annals of Surgery, I don't know if Dr. Maythal is here, that did try to match those patients as best as possible. So this is what ended up happening. And you can see there, I'm going to point the direction to the right, is actually the intraoperative ultrasound, where you can see the portal bifurcation. And then you'll see the tumor, which is the kind of gray island in the middle of the white with the stent going through it. And so I think for Dr. Baker's benefit and the other surgeons, you can see that it's truly just a hilar lesion, not involving the pedicles. And so I'm curious as to, you had mentioned you would have done a left-sided hepatectomy, which, good, that's what we ended up doing. So can you tell us a little bit about why you chose the left versus the right? Because you could, as you can see, you can probably approach it either way.
So these are the challenging things, and these are often decisions that you make in the operating room, how you're going to approach this. So the intrahepatic component that you're showing right there anatomically is in the base of segment 4, which is part of the left lobe of the liver. So that's why I would choose an extended left hepatectomy at this point. And I think to your point, you already put that in there. One of the things that has really improved overall survival for these patients is including the caudate. And again, that's one of the reasons that you really want to go to a center who is used to doing these with their multidisciplinary colleagues, because often the caudate is not done, and the most common place where the tumors recur is in the caudate lobe. And that is just honestly plumbing. It's just the functional effect of, at that bifurcation of the bile ducts, just where you see the stricture right there, there's always consistently, probably more than 99% of the time, a small duct which goes down into the caudate, so the caudate has to be presumed to be involved, whether it is radiographically or not.
Yeah, and I think, again, some of the technical pearls, as Dr. Baker was mentioning, is that left-sided hepatectomies tend to be also better tolerated in the sense that the right liver is the bigger liver, but the left-sided bile duct is a bit longer. So these are the things that we have to kind of weigh. But by far the biggest thing is also the blood supply, right? Because we have to worry about not only the bile ducts, but tumors run in 3 dimensions. So we got to worry about the hepatic artery. The left hepatic artery typically branches off early, so it's actually spared most of the time, whereas the right hepatic artery tends to cross either in front or behind the biliary bifurcation and often gets clipped by tumor. Oh, and here are the labels that are coming in. Those are the veins, and then there's the tumor. Okay, so this is the intraoperative picture, and I'm glad we got this before lunch. So, but you can clearly see here where the left liver has been removed, and you'll see the 2 little openings are the bile ducts that are going to the remaining liver, which is the anterior and posterior sector. So this is an interesting question. How many lymph nodes are required for a proper dissection? I'm going to pick on some oncologists who I see. We've already picked on Lippy, so let's see who I can see. Mark. John.
How many lymph nodes? Okay, 8.
Not one of the choices, but that's okay. No, this is obviously has been a moving target. I'll just, for the benefit of the group, we'll just keep going. But it's really recommended that we get at least 6 lymph nodes. And obviously, we as surgeons are not sitting there counting lymph nodes and putting them in a bucket. We rely on our pathologic colleagues. We basically just clear out all the tissue in the porta hepatis. But for staging purposes, we do like to get at least 6 lymph nodes to make sure that we're not understaging and having stage migration later on. And this is the changes. It's a nice summary from actually the group at MD Anderson with Dr. Vote and Dr. Duin Chin, looking at what the changes were for both hilar and intrahepatic cholangiocarcinoma. And again, you can see how these things that need to be updated every once in a while to keep us in check. And as Dr. Baker had mentioned, there is now the American College of Surgeons just putting out an operative standards for cancer surgery, and cholangiocarcinoma is going to be part of volume 3, which is due out very soon. And the idea behind this effort is to try to standardize cancer surgery across centers so we have less variability. So finally, we have the answer here. So this is the pathology from the specimen. So it is a perihilar cholangiocarcinoma involving the left duct and the junction of the right and left duct, and extending up the right anterior duct. 1.3 centimeters in size. And the final staging did end up being a PT2B N0. And it was an R1 resection because there was microscopic focus of tumor at the resection margin, which was not known in the operating room. You can see there the next generation sequencing that showed a KRAS G12R alteration. These are, again, more pathology pictures, but you can see the tumor there on the left, and then on the right is the actual positive margin, which actually, as you can see, was on a nerve. And so a lot of times you don't see it on the bile duct, which is what gets frozen, but then on the final specimen, you end up seeing tumor creeping along nerves, which is, it can happen in not only cholangiocarcinoma, but in other tissue as well. I don't know if you guys have any experience, perhaps Dr. Baker or Dr. Javle, about how to manage this.
Well, I'm going to lean on John. So, John, we have resected hilar cholangiocarcinoma, and perhaps you can tell us the results of BILCAP in this pathology.
So, thank you. So the BILCAP study. Oh, somebody's putting others up. The BILCAP study looked, for those of you who don't entirely know, compared 200 people who received capecitabine, 220 in fact, to 227 people who had just surgery. and there was a modest, and we emphasize a modest benefit for all those patients who had capecitabine. Did the group with R1 margins do worse? Yes, they did. But nevertheless, we know that that group was also helped by capecitabine. Actually, in the long-term data of the BILCAP study, which is in press at the moment, and I know at least a few people in the room have seen, the patients, the local recurrence rates were extremely high for most high for hilar cholangiocarcinomas compared to all the other types of biliary tract cancers. And actually, local recurrence occurred both for R0 and R1 resections. And there's a discussion around the pathology and how hard you look and what that means. And so what adjuvant therapy would you recommend? I'm looking at the list. Are you looking at the list as well? Sorry, I can't see what
Yes, the list is up. Hopefully you can see it.
The list is up. I would say certainly capecitabine alone probably is marginally ahead of all the others. In Europe, we have the Actica study, which compares capecitabine to cisgem, and I would offer that to the patient as well. To date, we haven't got a lot of data about radiation, but perhaps Ethan would like to comment on that.
That's where I was going next. Dr. Ludmir, any comments on this?
Thanks. No, and I know we're going to have a discussion about the single-arm phase 2 SWOG 0809 trial, which would be applicable in this setting, which really looks at the role of both adjuvant chemotherapy and adjuvant chemoradiation in that sequence. And in the setting of an R1 resection, what we saw in SWOG 0809 is that we see similar overall survival for patients on that single-arm trial who ended up having an R1 resection when we added adjuvant, both chemotherapy and chemoradiation. The big limitation of that trial, of course, is that it's not a randomized controlled trial. And so exactly to Dr. Bridgewater's point, the evidence is certainly not where we'd like it to be. That said, from a practitioner standpoint, institutionally, we tend to favor the SWOG 0809 paradigm.
And would that be the same if it was R0? Anyone?
I think, Flav, like John mentioned, I use BILCAP as adjuvant generally for intrahepatic without a problem. For hilar, I debate a little bit. And then sometimes, if it's R1, we do chemo-RT. If it's R0, I think we talk to the patient. Capecitabine, sometimes gemcis. But you're right, the only randomized data is capecitabine.
Got it. Any takers for any of the other regimens? Okay. So just to give a quick review, and I'm sorry that got shifted a little bit, but the role for this rationale for adjuvant therapy has been ongoing and evolving. And so this is one of the earlier meta-analyses and systematic reviews by Dr. Knox at Princess Margaret, looking at some of the smaller single institution studies that did appear to have a benefit associated with either lymph node positive disease or positive margin disease. I think this was sort of the landscape that we are aware of, and I'm glad Dr. Bridgewater has sort of updated us on the Actica trial. We do have data for PRODIGE, BILCAP, and BCAT to date, and I think ASCOT was just actually presented, so I don't have that up on this slide. It needs to be updated. These are actually the curves from those trials. So again, we did have a couple that are in the, that did not meet their endpoints. BILCAP was one that did, and we're obviously eagerly awaiting for that long-term data to come out, which, as John mentioned, is in press. We did kind of cover just a little bit about the SWOG 0809 trial, which was a single-arm study. It did include both extrahepatic cholangiocarcinoma and gallbladder cancer. Did not include ampullary cancers or intrahepatic cholangiocarcinoma. So these were resected patients that did get a combination of both systemic therapy with gem-cape and then had the chemoradiation. Small trial, 79 patients, just giving you a sense of how hard it is to accrue to adjuvant trials. This is the only one we were able to really do in the US to date. You can see the breakdown there between extrahepatic and gallbladder cancer, and you can see the survival curves there between R0 and R1. We did do a secondary analysis. This is done by my colleague, Dr. Golami at UC Davis through SWOG. This was presented at ASCO last year and is currently being submitted for publication. You can certainly see there from the curves that N1 disease does do worse, and we know that. However, compared to historical controls, this cohort did somewhat better. Again, it's hard to know for sure since there was no comparator. It was a single-arm trial. But one thing we were able to see is that there was appear to be a local control benefit there between the N1 and N0s, but we did see more distant failures in the N1 group, which is not surprising, which again makes you think that perhaps the radiation did have a local effect, but was not as good as controlling a distant disease, which is not surprising. So just to give you the closure, the patient did end up getting the 0809 protocol, so got the systemic gem cape, finished the radiation, actually tolerated it quite well. This is the surveillance CT scan, and you'll see the left liver is missing, some evidence of a surgeon being there with the clips, but has no recurrence and is NED at this time. John, question?
Yes, just to update the slide you had up earlier, the ASCOT data, the Japanese data, which is identical to the BILCAP study using S1, another fluoropyrimidine, was presented a couple of weeks back in San Francisco, and our Japanese colleagues have shared those data with us in some detail, and they are remarkably similar to the BILCAP data in almost every detail. Which is incredibly, the one has had a great deal of grief about the BILCAP data for years and years and years, and it's good to know it wasn't personal, and our Japanese colleagues have had exactly the same experience.
Thank you, John. So we have one final case, and I know we're going to make it brief. We started 10 minutes late, so I'm going to lean on Jesper and Lippy to borrow a few minutes from the next session. So we're going to have a little review on liver transplant, a few slides only by Talia, and then we'll have the following case, and then Ethan is going to talk about his experience in using radiation for large intrahepatic cholangio. And I promise we shall be done no more than 8 minutes after the hour. Yeah. We can have 15, so we have time. Thank you.
Thank you, and thank you for letting me speak about liver transplant for cholangiocarcinoma, which has already been admitted. And I think it's really important to acknowledge that there's not a lot of data for this. And a lot of the decisions that we're making are more based on wanting to do the best thing for every single patient who comes to us in a personalized manner than actual data-driven medicine. It's a hard place to be, but I think it's a really exciting time to be a liver transplant surgeon who's interested in this really new field of liver transplant oncology. So liver transplant for hilar cholangio, for these hilar lesions, was demonstrated almost 2 decades ago by the group out of Mayo and really shown to be highly effective. I'm going to figure out this AT stuff. So in the early days, Julie Heimbach really first showed that liver transplant for hilar cholangiocarcinoma had better overall survival than resection, and this was really exciting data. These data were very marred by the fact that, as you've already seen, hilar cholangiocarcinoma has diagnostic challenges, and there were questions as to whether these patients actually had cancer at the time of liver transplant. This was really followed up by a study by the Toronto group, which looked at early intrahepatic cholangiocarcinoma. If transplant was good for hilar cholangiocarcinoma, could we consider transplant for intrahepatic cholangiocarcinoma? And they showed that for very early intrahepatic cholangiocarcinoma, i.e. single tumors that were less than 2 centimeters, versus advanced intrahepatic cholangiocarcinoma, which were single tumors greater than 2 centimeters or multifocal disease, the survival data for those small tumors was actually as good with transplant as overall survival data that we were having for transplant as a whole. But the data for the advanced group showed that there were decreased survival, overall survival, 1-year patient and graft survival, which is the metric that we as transplant surgeons are held to. And therefore, we really started thinking about what could we do to understand the biology of these more advanced tumors so that we could potentially, with a multidisciplinary downstaging pathway, get them to transplant as well. So the Methodist group really spearheaded this. Carrie Lansford published the first small series of patients at MD Anderson and at Houston Methodist. It took into account 12 patients who had been considered for a personalized approach to downstaging for locally advanced intrahepatic cholangiocarcinoma who went on to liver transplant. The results were really impressive. There was 100% 1-year survival, 83% at 5 years. I'm sure Dr. Javle could give us even a further follow-up. And interestingly, there was a 50% disease-free survival at 5 years. So this was hugely exciting to the transplant community, but we understood that these patients had to be really highly selected in a multidisciplinary fashion. This study was recently published, which is a follow-up of that initial group, again, from the MD Anderson Houston Methodist group. And again, they were able, in these highly selected patients who were brought to transplant after multidisciplinary downstaging pathways, which included various modalities, including systemic chemotherapy and liver-directed therapy, the outcomes were really impressive. And this made us, as a transplant community, really understand that we really had to think about different metrics for these patients than the traditional metrics that we were always held to, 1-year patient and graft survival. But we really started to have to think about, can we offer patients increased overall survival and increased quality of life despite potentially recurrence post-transplant in a way that was demonstrable. And furthermore, we also understand that we have to learn how to use the systemic therapies that our medical oncologists can offer and the liver and the directed therapies, including immunotherapy, in conjunction with the medications that we need to use to protect the liver, which are standard immunosuppressive medications. And the work that's been done in that in just the last several years has been really remarkable. Again, we're developing data. We don't have data yet, but I think it's a really exciting field to be part of. So these were the overall survival data, which are really impressive. And this really brought together a group in the International Liver Transplant Society to understand that we really have to, as a transplant community, in conjunction with our medical oncologists, our IRIO people, our surgical oncologists, importantly, and our rad-onc specialists, understand what's the best way moving forward to offer patients potentially better overall survival. And we hesitate to ever say cure, but potentially curable disease. So Dr. Sapochian just published this in the last month, and it's a really important study which shows that I'd asked the question of liver transplant for intrahepatic cholangiocarcinoma, are we ready for prime time? It demonstrates that in patients with cirrhosis, clearly transplant should be considered as a potential option. But Flavio just mentioned this. Even in patients without cirrhosis who have relatively normal unscarred livers who present with locally advanced intrahepatic cholangiocarcinoma, the results for transplant in the initial studies have been shown to be better than the overall survival for resection alone. So when you ask, should you be considering options for transplant early on, I think it's really important that you always ask that question up front. Understanding that we can try to get you to transplant, not every patient will get to transplant, but a dedicated effort with intent to treat treatment plans, including systemic therapy, including liver-directed therapy, including our radiation oncology colleagues, are really the way to go to get to a potential really good study, really good cure. So there's several prospective trials that are the governmental trials which are being done right now, looking at options of combining all the multidisciplinary pathways with transplant as the end game. These are really important because they kind of highly select which type of patient you fall into, but importantly, none of them stop at transplant, and acknowledge that we as a transplant community have to continue working in our multidisciplinary pathway post-transplant to include modulation of immunosuppression and potentially systemic therapy and immunotherapy to our treatment algorithms. When we look at this, the way our group works, and I think this is really how most multidisciplinary pathways are going, and again, don't get caught up on the details of this, but I think it's important that when a patient comes to us with locally advanced intrahepatic cholangiocarcinoma, perihilar cholangiocarcinoma, or hilar cholangiocarcinoma, this is the way we start thinking about the patients. We know that we have to define the disease, do metastatic workups, et cetera. We often start with a systemic chemotherapy option as the upfront disease biology definition standpoint. We then most frequently use liver-directed therapy as one of our potential downstaging approaches as well, in conjunction with capecitabine, which is not only, as Dr. Salem has shown, able to enhance the effect of the radiation, so it's a radiosensitizer, but also effective against circulating tumor cells, which cholangiocarcinoma may have as well. We then follow that with another round of systemic chemotherapy, a recovery phase when we allow the biology of the disease to really declare itself, and then surgery. And because we work so carefully with our surgical oncologists, the surgical options that we can offer at that point can be anywhere from a simple resection to a very complex ex vivo resection to the ultimate radical resection, which is transplant. And then afterwards, we actually follow very carefully the BILCAP data, and I'm pleased to hear that it's being replicated across the internationally now, because we really believe that capecitabine, for example, can be used in conjunction with modulated immunotherapy to offer, again, the patients the best chance for overall survival. So with that, I will say thank you, but I'm very curious to hear this next case.
All right, well, in the interest of time, we're going to hop right at it. So this is our kind of third and final case. So this is a gentleman. He's also fairly young. He's 53. He has some abdominal pain and a little bit of fever. And this was actually in the height of COVID. So, at first they were worried he had COVID, but sometimes it's not COVID, it's something else. So he was evaluated with some imaging because of the abdominal pain. His liver enzymes were actually essentially normal at this point in time, but what was most remarkable was that the CA19-9 was 2,651. For this lab, the reference range was from 0 to 35, so you can appreciate that it is very, very elevated. And importantly, the AFP is normal, which argues much more strongly for a cholangiocarcinoma as opposed to a primary liver cancer. So this is kind of an overview of the CT abdomen and pelvis with and without contrast. And this is wholly insufficient, unfortunately, for some of our surgical colleagues. But for the benefit of the audience, you can see the liver is a little bit enlarged. So you have some mild hepatomegaly going on. And you have a pretty kind of obvious mass kind of sitting right there in one side of the liver. So some of the other background medical details, this person was on orthodilol. He has diabetes mellitus type 1, so he's on insulin because of that. He essentially has no surgical history. He is a veteran, a healthy gentleman. And in terms of family history, he's part of a very large family. His father had suspected liver cancer. They were never really entirely certain what kind of cancer he passed from. A maternal uncle had Hodgkin's lymphoma, and then a paternal uncle also had some sort of unknown type of cancer. But otherwise, in a very, very large family, there were no other cancer diagnoses in the family. Chronic liver disease, clean, nothing really popped up. And so as kind of one of the theme goes, diagnosis is important. And fortunately for this gentleman, he underwent a ultrasound-guided liver biopsy, and kind of in one go, he had a diagnosis of moderate to poorly differentiated adenocarcinoma. And given the supporting evidence with the AFP being normal and the CA19-9 being highly elevated, and some of the other immunohistochemistry stains that I didn't include in the slide, he was given a diagnosis of a stage 2 cholangiocarcinoma. So at this point in time, I would lean on our panel. I think we've already discussed quite a bit over some of the factors that play into surgical candidacy. But for this gentleman, he was some tumor encasing the hepatic artery and abuts the portal vein. And perhaps at this point in time, I can lean on some of our panel to kind of discuss some of this treatment decision for upfront treatment.
Can I interrupt for a second? So, Flavio, this patient was also seen by was not thought to be resectable. I take it to my colleagues on my left, they would also consider Y90 in this situation. Is that right? Is there a certain vascular pattern that you look for, or is there certain perfusion characteristics that will influence you before making that decision?
Yeah, one of the things that we've gone to answer that specific question at times is to just do a diagnostic hepatic angiogram, which explicitly answers that question. So for that example, that case, it appears that there's part of the tumor that's sort of towards the middle hepatic vein in the middle of the liver, which would make a resection challenging, other than the hepatic artery portion, but from a surgical standpoint. And invariably, the diagnostic angiogram on this patient, when you injected the right hepatic artery, it would all be crossing over to the left. And so this person, if we were to do a local regional therapy, would be a left hepatic artery and the anterior sector to clean that margin, to create that scar tissue across that surgical plane for Flavio and Talia to resect.
I think it's also important, I'm sure Flavio, you would say this as well. This patient is not upfront resectable because of that involvement of the extrahepatic pedicle, but that doesn't mean that we can't work towards getting them to a point of resectability. Whether that resection is a resection up front or transplant can't be really determined at this point. But to Riad's point, I think that you can use Y90 as a way. One of the things that radiation does in favor of chemoembolization, for example, is what we've seen is when you give Y90 when a tumor is abutting the middle hepatic vein, for example, because of the radiation effect, it almost pulls the tumor away from the venous structure, the major vascular structure, which allows you to get be more likely to get an R0 rather than R1 resection.
So great points. Now, Flavio, clearly we would want to get people like this to neoadjuvant, whatever therapy, and get to resection. But what is the recurrence rate of these high-risk tumors who actually go through that route and go through neoadjuvant therapy and surgical resection?
Yeah, so this is what we were referring to earlier, is that there's the technical exercise and there's the biologic exercise. And so even in the most resectable tumors in cholangio and intrahepatic cholangiocarcinoma, the resection rate is still about 60%. I mean, the recurrence rate is 60% at 2 years. Now, if you throw a bigger tumor, multiple tumors, positive lymph nodes, that resection is 90 to 95%. And so again, it's not the question of getting the tumor out, it's treating the micrometastatic disease, which the neoadjuvant approach makes total sense. And I know my colleague, Dr. Maithel, is here, and obviously with our colleagues at the Mayo and MD Anderson, we did just complete accrual for the first neoadjuvant chemotherapy trial with gemcitabine Abraxane. So that's now being considered for presentation, and we hope to have that data for you here next year.
Did you have a question? Yeah.
So a lot of times a lot of people get upfront resections and then it reoccurs, and then they treat that and they might get a little while and then they treat something else where it shows up. And it might take them 5 or 6 years to completely rid their body, but that seems to be a lot of the long-term survivors who are now NED, that's their story, is that you just kind of keep hitting it where it pops up. So do you have any studies that look at, like, you have a reoccurrence at resection of 60%, but what about, like, further out, how many people are actually dying from the cancer when you're doing that? Does that make sense?
No, it makes total sense. So again, and this is where I think a lot of the advancements have been made, in the sense that can we, even if you recur, can we control the disease? And that's where having my colleagues like Dr. Salem and others, and Dr. Ludmir as well, because I know we're going to get to his discussion on radiation, is the challenge with this is that sometimes what ends up causing the problems is it's a tumor factor, it's a liver factor, meaning it's not that the cancer is spreading wildly across your body, but it's just taking up so much liver that the liver fails. Or it's also, as we hinted for the hilar cholangiomas, it's an infectious process. So you just get the stents in and out, and the cholangitis, and the bile ducts get scarred, and to a point that there's not recoverable.
So Dr. Ludmir is covering some of these points when we get to his discussion. So you can go on, Tim.
So for some of the molecular data that was acquired, kind of as we were talking about earlier, sometimes for these very large necrotic tumors, it can be very challenging to get solid tumor DNA and genetic testing off of it. And so unfortunately for this patient, both the DNA and the RNA was considered inadequate, so we don't have mutation data at this point in time, nor do we have fusion data off of the solid tumor. From our liquid biopsy panel that was done in-house, there was no findings. However, very interestingly enough, on the liquid biopsy panel, it was actually flagged in our institution as a potentially pathogenic BRCA1 mutation being found in a germline setting. And some of that just has to do with how frequently you see the mutation when you look at some of the raw next generation sequencing data. But we'll put a pin on that and keep it in the back of our heads as the story progresses that, hey, on our liquid biopsy, there's a concern that maybe this person also has a BRCA1 mutation.
Could you explain germline mutation?
Yeah, so, I think right now we're talking a lot about molecular testing in a lot of different scenarios. So one of the things that patients should always keep in mind is that when a physician talks about genetic testing, you should probably ask about from what tissue and in what setting. So when we talk about germline, specifically germline genetic testing, this is what we think about when we think about cancers that run in the family. Of course, BRCA is most famous is actually a breast cancer related mutation or something along the lines of hereditary breast ovarian cancer plus pancreatic cancer at this point in time. But when someone says germline genetic testing, they're drawing your blood and they're testing you as a person, kind of head to toe. Did you potentially inherit any pathogenic germline mutation from one of your parents? This is in comparison to when we say tumor testing or somatic testing. So there's a difference between germline and soma. Soma is your tissues that arise later. So for somatic testing, there's a difference between tumor testing as well as cell-free circulating tumor DNA liquid biopsy. For solid tumor genomic assay, you're actually isolating DNA and RNA directly from the tumor itself, and you use that kind of sample to run through your testing. And just because of the way the testing is done, RNA testing is usually much more sensitive for fusions. To detect fusion transcripts, you usually need RNA for that, and that has implications actually on the biopsy itself because of the fact that RNA is a much more unstable kind of molecule compared to DNA. But in a highly necrotic tumor, which is, presumptively what happened in this case, both DNA and RNA, the quality is just too low to really reliably do any of these really sensitive molecular tests. And this is in comparison finally to the newest one, which is cell-free DNA. I think earlier I heard circulating tumor cell DNA. There's been a lot of different thoughts over, can I just draw blood and somehow extrapolate to the tumor itself? So there is an extrapolation process in play here, and that's why we heard earlier a little bit some of the need for some of the machine learning algorithms to kind of isolate exactly what is tumor DNA and what is DNA from you yourself, because again, it is the same blood draw. The magic really happens at trying to separate out what is tumor and what is you, and that's some of the really kind of technical challenges that have been overcome in the last couple of years, but still continues to need to be overcome. But because of the nature of circulating tumor DNA or cell-free DNA, you can actually try and run fusion testing right off of that same sample too at the same time.
Thank you, Tin. Tin has a PhD in genetics, so he can talk a lot about it. Go to the next slide.
Sorry, I'm a clinical geneticist, not a PhD, but I'm a clinical geneticist. So we'll move on. Yes, and sorry for that long aside, but we'll move on to this point in time. I think this is to the benefit of some of our surgical colleagues. This person, of course, undergoes upfront therapy with gemcitabine cisplatin, and during all of this, there's this question of what is this suspicious-looking lymph node that we see on imaging. So this person actually gets a FNA on a periportal lymph node, and actually it's clean. No metastatic carcinoma was identified. And so at this point in time, what we really have is this patient has been on gemcitabine cisplatin, but he has in fact liver-limited, locally advanced intrahepatic cholangiocarcinoma. So at this point in time, I would kind of direct this discussion to our panel members. When would you stop? When would you stop with this upfront chemotherapy for a liver-directed, for a cancer that's limited to only the liver? And what kind of other treatment options would you consider at this point?
John, you have published on patients who have liver-limited, locally advanced intrahepatic cholangio that have negative lymph nodes. This is liver-limited multifocal cholangio with negative nodes Could you discuss a little bit about your JNCI paper and what is the prognosis of these people?
Yes, thank you. So liver only. We looked at the whole population of patients with initially inoperable disease in the whole of the ABC series, so ABC 1 to 4, which came up to around about 500 patients in randomized clinical studies, and they did much better. They survived at least 50% longer than the patients with extrahepatic disease. And so, was that purely because of the volume of cancer that the patients have? Is it something about the cancer itself that restricts it to the liver? These are questions that we should really consider, and it gives the opportunity for considering further local therapies in this patient population.
And I think this is a good point, because the question is, now that you have this, you've done your test of biology, this is sort of localized to the liver, now you can talk about the different local therapies you can give. And I think it's important to realize, again, the sequencing is important, because some things may burn the bridge for other things. So, for example, this might be a case where we might consider putting a hepatic artery pump in, because we know that works well for disease control in the liver. At the same time, we actually remove the portal lymph node. So if there's any question of lymph node involvement, they would be taken care of. Another option certainly would be the Y90, would be radiation. But keep in mind, this is the catch, the caveat. For patients who've had previous Y90, we cannot put a pump in, but the reverse is okay. And then I'd be curious to hear what between Dr. Ludmir and Dr. Salem about Y90 versus external beam radiation, and if one either trumps or negates the other.
Yeah, so Flavio, we're going to have that discussion at the end of this case. How do we choose the right local therapy? I'm going to require, I think Talia wants to make a point, because this patient was referred for transplantation. We'll see what she has to say, and then I'm going to turn it over to Dr. Ludmir, because he's in his radiation office rubbing his hands in anticipation, because this patient is expected to go to his office.
Absolutely. I think most of the points have been made, but I do think that at this point, one of the important things that we as surgeons have a hard time doing is, certainly a local therapy is taking out the tumor at this point, and that's certainly an option. But we know from the long-term data that's probably not the right option. It's not the option that will give the patient the best option for overall survival, and importantly, it does burn bridges for other potential options. So I would favor at this point, some type of local therapy. Just because it's been my practice, I always encourage consideration for TARE for all the reasons that Dr. Salem said. One of the advantages of the angiogram in TARE is that at that point you can really define the extent of disease, which is important to do in a way that's much more sensitive and specific than almost any other study that we can do. Furthermore, we can treat the disease over time to, again, although we've defined biology over a course of a short course, probably 3 to 4 months with this much gem-cis, we still haven't defined what the longer-term biology of this disease is, and TARE allows us to do that. And again, TARE also allows us to, it's a great stress test for the liver. So we can tell how well the liver will respond to therapy based on the TARE, and make a really informed decision about whether an extended resection or transplant would be a better option at this point. It also, from a transplant perspective, gives us time, if we start thinking about intent to treat now and are considering liver transplant, to bring in the ideas of living donation and start working up a living donor so that we can have one at a time when it will be appropriately timed.
And the hypertrophy of the liver.
So Tim, do you want to tell us the disposition before we turn it over to Ethan?
Yeah, so if we go over to the slides, let me advance the slide. But one too many. So this gentleman, he finishes 4 months of upfront therapy with gemcitabine and cisplatin. We talk about him on our Tuesday night multidisciplinary tumor board, and we decide to proceed with proton beam therapy with concurrent capecitabine, while he undergoes consideration for liver transplant with our Methodist colleagues. And Dr. Ludmir, if you just let me know when to advance the slides, I will do so.
Ethan, you can describe your planning.
Certainly, and I think it's worth noting that this phenomenal panel has hit on some of the most important points, including upfront discussion regarding transplantation, the role of a drug like capecitabine to radiosensitize either for Y90 or for external beam radiation. These are all important considerations, and making sure that you're thinking several moves down the board, as Dr. Baker alluded to. If you were to engage and pursue a local therapy that would compromise something else down the road, surely that if you can find a better alternative, that's preferred. In this case, after multidisciplinary discussion and consideration about Y90 versus external beam, we favored external beam for this case after discussion with Dr. Mavash, considering vascular supply of this tumor and other considerations. And given that we wanted to consider this patient for transplantation, Tim, the only thing is right now we actually don't have an actual live stream, so I don't see what slide you're on this second.
This is on
But if you're on the slide that starts with treatment, you might advance to the next one saying proton beam therapy, which shows a pretty colorful picture. One of the things we wanted to pursue was proton beam therapy in order to consolidate all of the disease we could radiographically see and identify. We used a regimen going to 75 gray RBE and 25 daily fractions, which is slightly more protracted dose that we tend to favor for left-sided tumors, given some variation in respiratory management and filling of the nearby luminal structures. The benefits of proton beam therapy over photon therapy like IMRT are something that comes up a great deal in the population at large, and there are centers that only do proton beam therapy that'll make you convinced that protons are the greatest thing since sliced bread. They're not. Different particles have different advantages, different techniques have different advantages. The reasons we selected proton beam therapy in this case was to really ensure that we have a steep dose gradient to keep radiation dose off of the hepatic hilum, and in order to allow our transplant colleagues at Methodist, with whom we discussed this case extensively, the optimal chance of ensuring that any of the tissues that would need to be resected or reconstructed as part of a transplant would not be exposed to excess radiation such that it would compromise the surgery. Tin, I think I'll turn it over to you because I think the next parts deal with the molecular data for this patient.
Yeah,
Is that right?
so, thank you, Dr. Ludmir. This patient, he did undergo confirmatory germline genetic testing, and the culture here in the U.S., at the very least, is that a lot of the times a mutation is flagged either on a liquid biopsy or on a solid tumor test itself. You actually, for the patients out there, don't be alarmed if you get referred to a different specialty for quote-unquote confirmatory germline testing, just because of the massive implications on potentially your family and kind of how you think and appreciate kind of some of your risks for cancer. There is a genetic counseling process that undergoes a lot of the times for confirmatory genetic testing. So this patient actually does get confirmed to have a pathogenic germline BRCA1 mutation. And at this point, I just want to point out that these old hereditary cancer syndromes, in case BRCA1 has been traditionally thought of as HBOC plus pancreatic cancer more recently, we are seeing these germline mutations come up in different cancer patients in cancers that are outside of these traditional syndrome spectrums. So there's kind of evolving data and discussion in the clinical genetics field over when do you test more broadly, which patients should you test, so on and so forth. But in this patient, I just wanted to point out that this patient has a germline mutation in BRCA1, which potentially has consequences on some of the molecular characteristics of the tumor that we do not have at this point in time, specifically HRD or homologous recombination deficiency. And at this point in time, this patient tolerates proton with concurrent capecitabine very well. So at this point in time, he has had 4 months of gemcitabine and cisplatin, has had proton beam therapy with concurrent capecitabine, and the tumor has responded. On the kind of right side, we see one of the images that shows a little bit of a shrunken appearance, some post-radiation changes to the surrounding liver itself. And so I'll leave it to the board at this point in time. What other treatment options would you consider at this point in time? So keep in mind that he's still undergoing liver transplant evaluation.
So for the sake of time, maybe then we can move on. The patient, as you see, had a very good response to protons. You can see a CA99, so Ethan did a wonderful job. The patient was put on observation after this, and we waited for transplant. And then 7 months after being listed for liver transplant, he went to the VA because he had an altered mental status. He had headache, and his wife found him confused.
So here we have the workup for it. This is images taken from MRI of his brain. This is a T2 flare. For those in the audience, anything that lights up really highly here is inflammation. So we can see in the top right image right there that you see kind of a circular, slightly darker mass right there. That is most likely an oligometastatic foci and with a lot of cerebral edema, kind of moving kind of down. But one of the main takeaways for this image really is that we are considering this patient now to have quote unquote oligo, which is few, metastatic disease, is the primary suspicion at this point in time. So perhaps our surgical colleagues can discuss a little bit on the role for surgery for oligometastatic disease.
Gosh, I'm neither a rocket scientist or a brain surgeon, so I'll pass.
Well, I think the idea really is that if you have oligometastatic disease, they keep on increasing the amount of disease that you can have and still qualify for a potential resection. So this gentleman, he had a craniotomy, so they opened up his skull, and because of the fact that that tumor foci had favorable anatomic location, they were in fact able to resect him, which takes us to our next question of, after you have resected oligometastatic disease, the inflammation has calmed down, is there anything you would consider? And Dr. Ludmir.
So I'll hop in for a brief moment, Ken, because the concept of oligometastatic disease, I think for patients, is also one that has come into vogue over the last 30 years. The notion being that there are patients who have a relatively limited number of sites, either when they initially get diagnosed with metastatic disease or potentially when they recur. And randomized controlled trials have demonstrated that there is an overall survival benefit for certain patients with certain cancer types, and this does not include cholangiocarcinoma, as the numbers are quite simply too small to have ever run a trial in this setting. Although we have been exploring this to some extent, the numbers are very challenging. However, the extrapolation of those data suggests that if you do have a limited number of metastatic sites, and this speaks to points brought up earlier by the panel, an isolated recurrence, things like that, where local therapy can be serially used to control the disease radiographically. And this is thought to both improve progression-free survival and overall survival. With regard to this specific lesion, a single brain metastasis, there are data from across the spectrum of brain metastasis literature that the optimal approach for local therapy and for control of disease without compromising neurocognitive outcomes is to resect the tumor and then follow that typically with stereotactic radiosurgery to the cavity. And this both optimizes local control and prevents neurocognitive decline rather than doing, say, whole brain radiation. And that was what was done in this setting.
So we have 6 minutes,
Yeah, so kind of running through the next point, because of the fact that we had this craniotomy, we had additional tumor. So we sent this tumor off for, or I shouldn't take credit for my clinical colleagues. Our clinical colleagues sent this tumor off for additional genetic sequencing. At this point, you can see on the right side that I felt the need to even put it into an Excel sheet because of how many findings there were. So kind of hitting kind of at the main points, the microlite satellite status is high. So these are kind of small fragments in your DNA that are highly repetitive, but has been traditionally used as a potential marker for response to immunotherapy. You have a tumor mutational burden right there. 20 mutes per megabase is very high. This is a very, very high tumor mutational burden. So the MSI stats and the TMB potentially qualify this patient for immunotherapy. There is a basket approval for tumor mutational burden associated with immunotherapy. And the other things is that you can see that this person has quite a few other kind of genetic mutations in the tumor itself that we picked up on. Of course, we recapitulated the known germline BRCA1 mutation, but you can see that actually somewhat curiously for those that pay attention to some of the genes that are mutated, you can see that there are potentially some genes that are mutated that have to do with mismatch repair. So BRCA1 has specifically to do with homologous repair deficiency, and the way that normally manifests itself in tumor is not necessarily in hypermutation. So what we're seeing right now is that this tumor is highly mutated. It is potentially quote unquote a hypermutated tumor, although there is no kind of formal consensus definition of what qualifies as hypermutation.
So
but
this patient we are referred for MSI testing, right then? And the patient is now
we did.
on pembrolizumab, doing very well, and all the disease is controlled. So I think the point Tin wanted to illustrate here is that the need for molecular testing does not end with one negative biopsy and inadequate DNA sample. So we didn't actually pursue another DNA testing afterwards. Fortunately, we got another one when we sent his brain tumor for profiling, and that turned out to be have MSI. So the patient is doing well and tolerating therapy well. Now, while we have just about 4 or 5 minutes, Flavio, we discussed local treatment options for the liver. You mentioned 5-FU. To my left, there was great advocacy for Y90. And behind me, Ethan is talking about radiation. So how do you decide between these therapies, and how do we actually make this decision in clinic?
Yeah, again, I think this is where the multidisciplinary discussion is key, because there's a lot of things we can do. The question is, what should we do? And we do have to tailor these. I mean, this is a great example of therapy that was tailored to the individual, not just at the molecular level, but at the liver level, at the patient level, and so forth. So I think it's great that we have lots of options. We just have to sit down amongst ourselves and figure out who goes first, who goes second. And again, the idea is to keep the most options on the table and not burn any bridges.
So we may have time for maybe one question. If not, I'm going to ask Flavio to make any final comments.
This is Shishir. Can I just make a comment about the philosophy and concept of oligometastatic disease? I think it's a moving target, and as our therapies expand and we learn more about the disease in general, our willingness to act on oligometastatic disease is changing, and it's a moving target. But anytime we resect a multifocal tumor, we're resecting patients with oligometastatic disease, whether you call it T2, but intrahepatic metastases are the most common. And when we do these cases with, this biopsy, the lymph node was negative, but oftentimes we have positive lymph nodes. We give them the 4 months of chemotherapy, and then we take them to the OR. Those lymph nodes are oligometastatic disease, and previous staging system, they were stage 4. Now they're stage 3 on the 8th edition, but they were considered stage 4, so that speaks to the biological implications of lymph node disease. Now, when you have an oligometastatic brain lesion, I think it's hard-pressed to find a surgeon who's going to take that patient to the OR for a major hepatectomy. So location and number, well, we're saying oligo, so let's say we're all in the same number, but the location of oligometastatic disease really plays into our decision. And whether that's right or wrong, I don't know. Whether or not a met in the liver versus a met in the brain, whether it's one each or one lymph node, whether that means something different, I don't know. But that's how it always plays into it. I think it's a moving target.
I also think that it's dynamic, and you really have to continue to consider the patient. If this patient, as you point out, that oligometastatic disease, yes, it's alarming that it's in the head, but it's not different really than how we look at lymph nodes. So if this patient does well over, the timing is going to be up to, it's something that we as a multi-D team would have to decide, 6 months, 9 months. I don't think this patient, certainly liver transplant is probably off the table at this point, but a complex resection where probably it looked like the hepatic artery and potentially even the portal vein would have to be reconstructed with exogenous vein, with graft, what you could make a lot of decisions about there. I don't think ultimate surgical intent is necessarily a non-issue ever. I think you can still get there.
I think that's the theme of the sessions. One size does not fit all. With that, we're going to close the session just to keep us on time. I really want to thank my expert colleagues here, thanks, including our MD Anderson Fellow, and our colleagues who are joining remotely, especially John, because it looks like it's midnight now or later. And thanks, Ethan, for hanging out with us. Thank you very much.